Thank you all for inviting me. Just quickly, by a raise of hands, how many are pediatric nurses? Yay! Okay. I'm going to be speaking to several nurses. I do think that my talk is going to sort of blend all of the previous two talks together. I think and hope that it brings a little more clarity as to how you think about caring for our patients, of course, across the continuum of care. So I'll be talking about quality care and improvement in the pediatric IBD patient. What should we include in quality care and what should we monitor? So I'm hoping by the time that you leave here that you'll be able to understand the importance of quality measures and that you'll be able to find at least one intervention that you can do at home in your practice with your patients. So what does quality mean in the clinical setting? Well, applying evidence-based practices in a consistent, standard, and reliable manner to improve patient outcomes. This should be for each patient for every visit. And although the goal is to provide evidence-based standardized care, as we've heard before, some patients don't fit the mold. So in quality care, we use the 80-20 rule. 80% of the metrics, 80% of the interventions, 80% of the processes do a perfectly good management style for those patients. And then we have, unfortunately, a couple of the case presentations today where they would need more personalized approaches. Okay, so this is interactive. I've done my part. It's now your turn. So what does quality mean in the clinical setting? It means that we do standardized approaches to the investigation, the initial workup, so that every patient gets the same diagnostic tools. It means that when we start medications, that we are monitoring that medication in a similar and effective way. And particularly in our pediatric population, we are ensuring that they're getting a standardized evaluation for growth and nutrition. So when you're in a GI clinic and two adolescents walk into the office, brand new patients, both look like crap. Thin, pale, dark circles under their eyes, hunched over with their belly hurting, lost weight, complaints of bloody stools. How many in this room think you're going to start working these kids up for either ulcerative colitis or Crohn's disease? Oh my gosh, stop it. Yes. Anybody else? Okay. So what is that complete diagnostic evaluation mean to you? What are you going to do? Blood work? Okay, fecal cow. I heard. Okay. Upper and lower. Small bowel imaging. We got a pediatric patient here. Yep. Seth throat and nutrition. And then obviously there's other, stool studies and those kinds of things that you'd want to consider in the psycho. Right. How much is this affecting their daily life? How are they able to actually, go to school, play sports?
Do you use a standardized, we do a HEADS assessment. Do you have a standardized?
We do. We have, it's called an IBD patient and parent, it's not validated, an IBD patient and parent intake. It's aspects of the Harvey Bradshaw, but it's patient and parent reported, so it captures, within the week.
Can you repeat that one more time?
It is complements of the Harvey Bradshaw. Yeah, so it's the Harvey Bradshaw, but it's kind of morphed where we've added some patient-related outcomes on it. But it asked about, kind of basic symptoms for the week, energy. It also talks about impact on the social situation. How many times have you missed school? How confident are you in managing your care based on your best? How do you feel now? Kind of a global assessment of their previous week. So here's our two patients that walked into IBD clinic. Dylan is a 15-year-old male, bloody stools, weight loss, and abdominal pain. Kayla is a 13-year-old female, same symptoms. Dylan is going to see Dr. Bob. Kayla is going to see nurse practitioner Betty. So what workup would you do for these two kids? The entire thing?
Yeah, the same.
Yep. That would be the complete diagnostic workup? Okay. Well, Dr. Bob, he did some blood work on Dylan and found that he was anemic. He did his upper and lower endoscopy, thought it really did look like colitis, so opted to not do the small bowel follow-through, and he assessed his growth and nutrition. Now, my dear friend, nurse practitioner Betty, she did the full complement of labs. She had an upper and lower done. She also decided that it was going to be really important to get the small bowel imaged, and we use a lot of enterography. And if we've never had an enterography done before, we usually start with a CT, and then we always have follow-ups with an MR enterography. She had a dietitian assess her growth and nutrition, and she also sent some stool studies. So what do you think Dr. Bob diagnosed Dylan with? What do you think nurse practitioner Betty diagnosed Kayla with? You guys are good at this. Ta-da! Yes, so Dylan was diagnosed with colitis, most likely ulcerative colitis, although infectious colitis could not have been ruled out. Kayla was diagnosed with small bowel Crohn's and with Crohn's colitis. So what did we miss with Dylan? What could have potentially been more beneficial to him? Stool studies? Small bowel follow-through? And what did we find out about Kayla that we don't know about Dylan? Yeah, that she hasn't, yeah. So we potentially missed the small bowel involvement with Dylan and whether or not he had a stool pathogen that we should have been worried about. But with Kayla, we know the full extent of her disease, and we also ruled out the fact that this is not an infectious process, so that we don't need to start with Flagyl as the precursor to the rest of our treatment. So both of our kids, now they have their diagnosis, and we're going to start them on some medication. Therapeutic monitoring of medication should also be approached in a very standardized practice. These are the common, top 5 medications that we would use for either one of these patients. So when you're going to see a patient and put them on prednisone or teach a family and patient about prednisone, what is some of the most important things to remember that you should do with every single patient? Is it a maintenance medication? It is for induction of remission only. So when you see colleagues or see patients as second opinions to your practice on rounds and rounds and rounds of steroids, you need to start thinking about some steroid sparing options. So remission only, we usually use the standard dose for up to 4 weeks, taper it off over 6, try to get them off for 16 weeks. What do we need to be doing during this time? Yep. And then the next thought is, what are we going to weed them off to? What's the next medication? So 5 ASAs may not have been helpful for either one of these two kids, but when you put a patient on 5 ASAs, what are some of the screening monitoring that you would want to do with them? Yeah, yeah. Keep an eye on those kidneys. Thiopurines could be an effective next line therapy for these patients, but, and we've gone over this, I hope that this is not repetitive, but again, it kind of pulls everything together. What are your screening and monitoring tools that you're going to do with thiopurines? TPMT ahead of time?
Liver, CBC with DIV.
Right.
Skin checks.
Right, right. And then with us, if they're still active after 90 days on the medication, then we do a metabolite level to see where we are, okay? Methotrexate, so also a very good next line therapy. What? Exactly. And what other supplements, what else do we have to do with kids? Very good. And we also monitor the CBC and LFT every 3 months. And then screening and monitoring for biologics. I hear screening for tuberculosis. hepatitis. That's more of an adult thing that the adults do. But this is a whole different project, and I won't stay on a tangent, but we are part of a immunization project as well. And we have found that even though our patients have received their hepatitis B immunizations, that by age 5 and 7, they have lost immunity. And so now we are rescreening our patients based on our infectious disease collaborators' recommendation and then re-immunizing in most cases. And then also with the biologics, if you live in an endemic area, which Cincinnati is an endemic area for histo, we do a histo screen as well. And then another thing that we do is after the fourth dose of the biologic, we check to make sure that they aren't developing antibodies and that they do have a good level. Pediatric patients tend to burn up these biologics faster than adults do, and we have found a significant number of pediatric patients who have already developed antibodies before their inductions are finished. So we always check on the fourth dose to make sure that that's not occurred. And if it's starting to look like they're developing antibodies or if they have a low level, then obviously we add a second agent or we increase the dose or decrease the interval. So Dr. Bob put Dylan on prednisone and mercaptopurine, monitored his CBC, that's a typo, liver panel every 3 months, and noticed that his liver enzymes were starting to kind of creep up. He did have some improvement at his 3-month visit, but he really wasn't back to baseline. Kayla, on the other hand, was started on infliximab. She was getting her routine screening of CBC, LFT monitored every 3 months, and her labs all stayed normal. And then on her 4th dose, she got an antibody and level checked. Her level was a little low, but she had not been, doesn't look like she was developing any antibodies. And she was really back to her baseline. So what happened with Dylan? Yeah. And what happened with Kayla? So Dylan, we didn't get a TPMT ahead of time, so we don't know whether, how he's going to respond to the medication. Should we have started at a lower dose? And then his 6-MP level was not assessed at that 3-month follow-up, even though he was still symptomatic. So we still don't know whether this medication, it's obviously not working for him, but we don't know why, so we can't intervene. Kayla, she returned back to her baseline when we assessed her infliximab level. Since it was a little low, we went ahead and adjusted up to 10 milligrams per kilo. And then in pediatric patients, growth and nutrition is equally as important. So in pediatrics, there is a very systematic way of evaluating growth and nutrition. There is an actual algorithm that we use to measure this. So they're either satisfactory, at risk, or in failure, and then there are actual definitions on what that looks like. The same thing for nutrition, satisfactory, at risk, or in failure. So if they've started to cross over percentiles for either, then we keep a closer eye on them. They see the dietitian on a regular basis. And then obviously if they're in failure, then there needs to be a solid nutrition intervention with goals. So from a growth and nutrition perspective, Dylan saw Dr. Bob and was told, you don't have to restrict your diet. You can eat whatever you want to. I think as soon as we get this prednisone on board, you're going to be feeling much better. So we won't have you meet with the dietitian today. At the 3-month follow-up, though, poor Dylan, he was considered at growth and nutritional risk. Kayla, on the other hand, nurse practitioner Betty, she had her meet with the dietitian, and it was a nice meeting. They set dietary goals, fluid intake goals. At her 3-month follow-up, she was considered to have a normal nutrition and growth. So in summary, quality improvement is applying evidence-based practices in a consistent and standard and reliable manner to improve outcomes for each patient. And again, not all patients fit the mold, but it's an 80-20 rule. You can find all of these care algorithms on the Improve Care Now Model Care IBD site, and there is the link. It is open for everyone, and this is where all of this information came from, except for the 2 patients.